Hey everyone, welcome to our show today. We are live on KDOW in the San Francisco Bay Area, the #1 healthcare broadcast in the San Francisco Bay Area, #1 women in innovation show across the US online. So get ready for Christy. We're going to get started with a very important topic that could cost not only legs, but lives. So join us in just a moment and stay with us right here on the Heart of Innovation.
AM 1220 KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the show. A Medicare glitch could cost thousands of patients their legs and ultimately their lives. It impacts people whose leg pain turns out to be a circulation problem called peripheral artery disease, a condition that in advanced stages is more prevalent and deadlier than prostate cancer, colon cancer, and breast cancer combined. 3 in 5 people who suffer a heart attack have peripheral artery disease or PAD, and many don't even know it, if at all, until it's too late. Right now, doctors treating these patients in office-based labs across the San Francisco Bay Area, California, and 23 other states are seeing claims denied for critical limb-saving procedures by Medicare contractors, Noridian and Novitas. Today, we're finding out what's going on. My co-host, Dr. John Phillips, is on call. So joining me as co-host is world-renowned vascular surgeon and Sirius XM Doctor Radio host, Dr. Todd Berlind. And also with us are Dr. Elliot Adams, a vascular surgeon directly impacted by these denials, and Dr. Bob Tahara, past president of the OEIS, who is on the front lines with Medicare trying to fight for all of our patients and all of our doctors. So welcome, everyone. Welcome, Dr. Berlin. I want to start out and really get your initial thoughts before we jump into the deep.
Yeah, so this was just brought to my attention. I'm based out of New York. I'm a vascular surgeon, like the others on this call here. And for our listeners, really what we're talking about is treating peripheral arterial disease in the outpatient setting, the office setting, which is really revolutionized how we're treating these patients. We've been doing it for about 14 years at NYU. I'm director of outpatient vascular interventions. And we've been doing these procedures for a long time, knowing very well with Medicare, there's no prior authorization process. We do the procedures that are indicated and we get paid for services. We do know with other insurers and payers, there's a pre-auth process, but that's never been the case with Medicare. And when I hear that other states are not getting reimbursed for these procedures, these are very costly procedures. The devices are very expensive. Stents, whether you want to use an atherectomy device, there's definitely a cost associated with these. And for doctors to not get paid for these procedures is going to be a big, big problem.
Yeah, how so? Dr. Tahara, how is this a big, big problem that Dr. Berlin describes?
So I think Dr. Berlin hit on the fact that oftentimes the devices that we use to treat and to save limbs, especially in the office-based facility, are pretty expensive. What a lot of folks don't understand is that when you get treated in an office-based facility by a physician who owns that, part of the physician is liable for all of the materials. And unlike when I'm in a hospital and I do a limb salvage procedure, the devices, every wire, every stent, every atherectomy device, every intravascular lithotripsy device, everything, every Band-Aid, actually I have to pay for. So the reimbursement that we get either from insurers or from Medicare, that doesn't really come to us as physicians. That is really fundamentally designed to offset the costs. So what ends up happening is these very, very expensive items, the physicians have to actually pay for and essentially front or float this money. And then we have to wait for reimbursement from the payers. And I think anybody who's ever run a business can understand what I'm saying, that if you have to spend, let's say, $100,000 a month for equipment and consumables, and now all of a sudden nobody's paying you for a month, that's a huge problem. And the issue is, if we don't have that, we can't pay our staff, we can't pay for electricity, we can't pay for the maintenance on the machinery, and we can't pay for more supplies to save more legs. So the problem just keeps compounding itself.
Can I ask you
And
a question if you don't mind, if jumping in right here? Bob, do we think that this is going to be a delay in payment or no payment at all? Any insight as to where we're going with this?
So I would be very, very confident that there will ultimately be payment rendered. And the reason I'm confident of that is Medicare, CMS, the Center for Medicare Services, has already valued, as part of the physician fee schedule, payment in the office-based and the ASC and the hospital outpatient arenas. That's already been done. These Medicare Advantage contractors are legally obligated to pay those services at the Medicare rates. But what we're seeing is how they're administering them, whether this is, gaming the system for float, or whether this is an honest error, although that one evades me a little bit since they've had years and months to prepare. I do think eventually people will get paid, but that doesn't lessen the severity of the problem at all, Todd, because as you well know, running a lab, there's a huge cash flow crunch. And it's not like the companies that sell us or provide these devices, or indeed our staff. I can't tell my staff, hey guys, come to work for a month and don't get paid. They've got families to feed. They've got electricity to pay. And up here in Northwest Pennsylvania, we need heat.
Yeah.
and
No,
Dr.
it's a
Elliot,
big problem.
I want to bring in Dr. Adams here. I am really, you're the first one that I actually heard about this from. I saw it on your LinkedIn. Describe the situation and what you're experiencing.
Yeah, so the impact to those of us out here in rural areas, I'm in rural Idaho, I think is especially severe because we don't have enough surgeons to treat all the patients with critical limbs. At the hospital, my partner and I spend most of our time treating carotids and aneurysms and things that can't be treated outpatient. Before we started this lab, we had around 90 to 100 amputations a year in the hospital. Now we're down to below 20 amps a year in the hospital because we can treat these patients so much more efficiently in our own office with our team and our devices. And it's just a much more effective process for getting blood to the foot and saving the leg. We can only do that as government contractors with Medicare if we are receiving reimbursement for those procedures. And since January 1, 2026, we received no reimbursement, and we can't remain solvent for more than a few months like that, which means these patients will go back to the hospital and wait weeks to months for their procedures, and amputation rates will rise as a direct result of it.
Right? Time is tissue with these patients.
Correct. Exactly.
Well, coming up
Yeah,
next,
often
right
we're in
here.
situations where we're treating patients without authorization, with the hopes that we'll get reimbursed on the back end, because you got to do what's right, but you can only do what's right for so long because you've got to remain solvent. Just like Dr. Tahara said, you've got to pay your staff, you've got to pay the employees, you got to pay the electrical company to keep the lights on. So the money
As
has
we
to come
say
in.
in the Navy, hope is not a viable tactical plan, right? You can't hope
Right.
that you're going to stay open.
No, and these patients are really reliant upon you, because I know with our Lifesaver hotline, we already, have been getting so many calls with the Medicare Advantage plans issuing delays and denials for these patients suffering from peripheral artery disease in the advanced stage known as critical limb ischemia, where they're up all night long with this debilitating rest pain where they have to dangle their legs over the side of the bed and pace in order to get through the night. I mean, this is no joke when it comes to PAD, and these patients should not be left to suffer. So coming up next, right here on the Heart of Innovation, we're going to tell you what we've heard so far from Noridian and Medicare, what silence may mean, and whether this is truly a billing glitch or something much bigger that could permanently reshape where limb-saving care is delivered, if at all. So stay with us. Don't go away.
Leg health can
There we go. We're still live on YouTube. We have commercials going on the radio. When we get back, I just was going to go into just the fact I did send a note, I think Dr. Tahara, you saw I sent a note to Noridian. That was really awesome. Their response was go talk to Medicare. And to me, that spoke volumes, because at first I thought, okay, maybe this is a glitch. And I know from being in media since 1999 how companies respond, to things typically. And if they are trying to get away with something, or they'll literally, pawn it off. And that's kind of the feeling I got when they said, well, don't talk to us, go talk to Medicare. And then Medicare says, we'll get back to media within 24 to 48 hours, and still crickets. So I'm going to, ask you, about just what you think this silence means, what you've heard so far that you can share publicly about this. That would be great. And yeah, Dr. Berlin, just jump right in, step right on me.
Okay.
That's what we
Okay.
do. No need to apologize. Just go right for it.
Excellent.
And then I'll take us back on this one, but be thinking, if you would like, feel free. We can, on the
30
third
seconds.
segment, if you want to take us back in, happy to have you do that.
Talking to me?
What?
Sorry, was that to me?
Yeah, on the third segment, after this.
Sure.
I'll do this one, and then
Excellent.
the next one, if you feel like doing it, you can.
Okay.
Usually Dr. Phillips and I just kind of switch off.
That's 800-932-1809.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. Dr. John Phillips, my amazing host, is on call at the hospital. So pinch hitting is my amazing guest co-host, Dr. Todd Berlin. And today we're talking about a Medicare billing issue that could force hundreds of office-based labs across California and 23 other states to shut down. That would leave patients with peripheral artery disease, a condition more prevalent and deadlier in advanced stages than prostate cancer, colon cancer, breast cancer combined, without access to advanced limb salvage care in their communities. We reached out to Noridian, which is one of the contractors in question, to Medicare, one of two. It's Noridian and Novitas. And Noridian actually just referred me to Medicare for comment. And as of airtime, Medicare has not responded, even though they said they would respond to media requests within 24 to 48 hours. Bob, you've been on the front lines with Medicare for years. How do you interpret this silence?
Well, I think you've got two separate issues here, Kim. The first issue is the contractor, and the second issue is CMS or Medicare itself. And again, there are tons of hardworking people who try to administer the Medicare program and get folks that are over 65 care. There's absolutely no question about this. And I really don't want this to devolve in anything political, but I would rhetorically say, do we really want our healthcare run solely in the United States by an agency that has service akin to the DMV that we're all used to? And that's just the reality. The reality is it's a large bureaucracy. It's extremely complicated. And so part of, I think, what you got is not necessarily overt malfeasance or avoidance, Kim. I think part of it is actually just the way the system's designed. It is not user-friendly. It's not even user-friendly for us. And, God, we've got decades just between Todd and I before we even add Elliot into this mix, right? So it's difficult to deal with. So I wouldn't read too much into the CMS silence from DC. I do give the current administrator some credit. I think he's trying to make some changes there. Dr. Oz, we'll see where this plays out. And I'm going to give him some time before I pass judgment on that. In terms of the contractor itself, I mean, they certainly could have responded. I think referring it to CMS is a bit of a delay tactic and quite frankly, a little bit disingenuous. The easiest thing could have been just to hit that head on, but my guess is they're not prepared for this onslaught because I think they weren't expecting a lot of people to raise a lot of noise so quickly, like you have on this show.
Exactly.
Yeah,
That's what I'm wondering, because
I'd love to ask Bob and Elliot this question. Do we really understand the scope of this problem yet? We've got two of these managed Medicare plans. I don't even know if we treat lots of plans in New York. I don't know if I've even gotten to all those plans. We're still in the month of January, so I don't know yet what I don't know from a what's going to get reimbursed and what's not. Do you guys feel that there's others out there that may also follow along and not pay?
Good question.
For
So,
sure.
so Elliot, why don't you tell how this all came to light for you guys?
Yeah, so Medicare, traditional Medicare is always our fastest payer on a revenue cycle basis. It's usually about 15 days from submitting claims to getting paid from Medicare. They're very consistent, unlike these Medicare Advantage plans, which is a whole other ball of wax. Immediately on the days we were supposed to start getting paid for our first case of 2026, denials, denials, denials. And this is just with traditional Medicare. We haven't even seen the Medicare Advantage patients' claims coming through yet. I'm kind of assuming at this point that problem is going to extend to Medicare Advantage because those plans are never easier to deal with than traditional Medicare. They never pay faster. They often don't pay at all, commonly deny, and you have to fight it on the back end for months. So I think this is just the tip of the iceberg.
So,
Wow.
Elliot was one of the people who raised this, and actually he raised it not just on LinkedIn, but he also posted on the Society for Vascular Surgery forums that we have that are private forums, which is where I saw it. And because we were at an OEIS executive committee meeting, OEIS as an organization tends to be a lot more nimble. So we were able to kind of immediately initiate a response. But I can tell you that since this has come to light, I've gotten 20 or 30 separate emails from people pertaining to the Medicare disadvantage plans, as well as to many of the commercial payers. And what Elliot just said is really true. What we're seeing is a wave of denials, denials, denials. Partially, there are some system issues where they haven't gotten the codes loaded correctly and they don't understand the linkages and that. So there is a technical component, which I'm more than willing to admit. But it's very frustrating for us to see this because, again, there's been months to prepare for this, and the codes reformulated have been on track for years. I mean, Matt Seidman from SVS and the guys at CPT from OEIS and SIR and Sky, which are other professional societies, have been working on this for years. None of this is news.
Yeah, I don't want to blow this out of proportion, but I think that it is the reality because I'm experiencing it on the front lines with our Leg Saver hotline. We're not blowing this out of proportion. These insurance plans are literally costing legs every single day. I can't tell you how many patients just for Medicare Advantage plans that the delays or denials have led patients to an emergency room where they ended up with an unnecessary amputation. And it's really sad. And I'm concerned that this is literally not going to be resolved anytime soon. And it's going to have a cascade effect. And I think Dr. Adams is right, unfortunately, and Dr. Tahara, to where Medicare Advantage plans are going to see that Noridian and Novitas are literally denying claims. And they're going to say, ooh, this is another opportunity for us to delay and deny claims. Are you
Yeah, this is
fearing
going to
the
be a
same
big
thing?
problem. The question is what to do. What can we do? I know Bob, you've stepped down as just past president of OEIS. I'm sure, OAS is probably our best chance at advocating for this. I'm the president-elect of VES, which is the Vascular and Endovascular Surgery Society. We can move pretty quickly and we're nimble as well. You would expect the society like Society for Vascular Surgery to be behind us. They have not supported private practice and OBLs like I wish they would have over past years, but should be in their wheelhouse with their clout to be able to help with this. The question is this on patients? Is this on providers? Is this on media? How do we fix this?
So what I would say to that, Todd, so one thing I don't want to lose sight of, because there's been a lot of strife in the past between these organizations and between, is it hospital-based versus private practice guys, academic guys versus OBL guys. The good news on an advocacy front is that all the major societies really are now pretty firmly aligned. And I really do have to give a positive shout out to the SVS advocacy folks, Megan Tracy and Joe Harani and Yazin Verhey, who really dramatically have stepped up. It's such a marked difference from years gone by. So I'll say that first. But one of the response timing issues, I think, and again, I said it before we were live, I think, we all feel this acutely because we're signing the front of paychecks and we're signing checks to pay for the supplies. Most of our hospital-based colleagues, it's not that they're better, it's not that they're worse. This isn't an urgency for them.
They don't care. They don't care. I can tell you
Well,
as
it
a
just doesn't hit
hospital-based
them.
physician.
I mean, I think they care in
Yeah.
a very cerebral fashion, but they're not looking at their practice checking account going, I can't make payroll this week,
Right.
right? And of course, there's always been this fallacy about the OBLs are so rich in money and all this other nonsense. So I think that's really a big part of it. I don't think it's overt malfeasance or anything else. And again, I think the advocacy people are pretty aligned. I think the problem has been some of these organizations, like you alluded to, are not nimble. And so they spend a lot of time collecting data, by which time the problem's already long gone. People are closing, right? So I do think that there's a real focus on the societies that do focus on this to be kind of the canary in the coal mines and really raise these alarms and start the work. And my hope is that our larger, what I call our parent organizations, will follow suit and really support this.
Sure.
Well, coming up next, right here on the Heart of Innovation, we're going to have more with Dr. Adams, Dr. Tahara, and my guest co-host, Dr. Berlin. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
I mean, going back to what you were saying, Todd. I mean, it's like I think they're supportive of the mission, but I think it's abstract. That's really the problem that I see right now. And in fact, again, I'll give kudos while we're on commercial break, and I know we're still on the record, so that's fine. But Megan Tracy, who's the SVS advocacy chairperson, she and I talk frequently to try and align these things, and she is trying to move the entire organization along and get a response because it is important. And the optics of not caring for private practice is horrible for a parent professional organization because, and I've been on record for a lot of years saying, I don't care if you're in private practice, you're an academic guy that specializes in complex thoracos. There's no vascular surgeon in America that's getting over reimbursed, right? We're struggling for this across the board. So everybody's got to support everybody. But I think there's a much more of an urgency issue for those of us in the OBL because we're signing the front of a paycheck, not the back.
Yeah. Right.
We're getting a couple questions coming in. I just heard that Julie is telling us that Noridian is now denying ASCs. They just heard they're first in the ASC. There's Arlene that's online that's talking about a major cash flow problem, of course, again, with the OBL and now moving into the ASCs. And then Dr. Lalazarian from Los Angeles, actually. We can answer this on air when we get back on the radio, but do we know if the denials are also extending to the ASC and not just the OBL? And that's what we just discovered from Julie Garfield, who's saying that Noridian is now, in fact, denying in ASCs as well.
Kim, the only other thing I'd add right here about these denials, because you've got 3 seasoned vascular surgeons on your show right now, but this problem extends to a lot of our folks in interventional cardiology and interventional radiology as well, who are out there doing the same type of limb salvage work that we do, sometimes a little bit different emphasis because they're not going to be able to do open bypasses and endarterectomies and things if it comes to that. But the problem is much broader than vascular surgery or organized vascular surgery. Some of the problems Todd and I were alluding to. It encompasses multiple specialties, hundreds of office-based facilities across the country, which is thousands and thousands of patients every week. It's a little bit nutty.
It is.
These codes being denied are so specific to one disease process in one anatomical distribution, and it's limb-threatening disease.
Yeah, I don't understand. Why does everyone seem to keep going after PAD? And it's just driving me batty. Why are
30 seconds.
These patients pay the price? What is it about this disease that everyone just is disregarding?
It's unintended consequences, Kim. We have had in the field of endovascular revascularization across multiple specialties, but vascular surgery is going to be the most guilty of this, internal fratricide, where we've had a lot of people raising publicity and a few very vociferously trying to cast aspersions on the motivations of people doing this work in the office.
1220.
Let's get this. Let's review all of this, but Dr. Berlin, do you want to take us back?
You
can take it. You can take it.
For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. Dr. John Phillips is on call at the hospital, so Dr. Todd Berlin is pitch hitting as co-host. And We're getting some questions coming in online. We are streamed at youtube.com/the @ the way to my heart. Dr. Michael Lalazarian is asking, do we know if the denials also extend to the ASC, ambulatory surgical centers, and not just the OBL? And it looks like Julie online is saying that Noridian is in fact denying ASCs. Would you be able to comment on that? Dr. Tahara?
Yeah, so the EOBs that I have seen on this specifically have stated that it's a site of service problem. So the contention that Noridian has been putting forward is that these codes will only be reimbursed in hospitals. That is factually incorrect. That is legally incorrect. That is regulatorily incorrect.
And we have another question coming in from Eric. Is there a specific CPT code that you've seen denied in your OBL, Dr. Adams? And is the denial with straightforward lesions or the new complex lesion CPT codes? You might want to explain for our audience what this means for those who are not familiar.
Yeah, so the new set of codes, unlike the old codes, now differentiates between a completely occluded or a complex lesion, which may take multiple hours to cross and treat, as opposed to a stenosis or a simple lesion, which is generally much more straightforward to treat. And that's a very appropriate differentiation. But we're seeing denials across all of those. We've seen it for stenoses, we've seen it for occlusions. I would have to look at my EOBs to tell you exactly which ones, but for sure, SFA stenting of an occluded SFA, which is a very standard procedure we perform for limb threat, is being denied.
Elliot, can I ask you, has anything been paid so far in the month of January?
No, we've not been paid
Nothing.
for any of these. Nothing.
That is amazing. Jeez. That's a big
And
problem.
this is just for peripheral artery disease. We're just talking about opening up the blocked arteries in the legs. We're not talking about, have you had any problems with venous? I mean, I know that these office-based labs also not only do arteries, but they also are able to get the circulation in the veins working properly as well.
Yeah, so specific to my practice in a rural area, I honestly don't have time to treat much venous disease because I spend so much time on aneurysms, carotids, limb threat. So I only treat limb-threatening disease in the OBL, so I can't speak to venous, but for sure, PAD.
So we've not had any reports of the other codes being denied, but the other codes didn't change. So we went from having 16 or 17 codes to 37, I think, or 39 codes. I forget off the top of my head. So it was a real expansion as we went into this straightforward versus complex situation. So it's really only been the arterial codes.
And so we just have Dr. Feldman, who's also commenting on our stream on LinkedIn, saying, beginning January 1st, we have been having significant delays in getting authorizations in South Florida as well, and they've yet to be paid for any of their cases using the new codes yet. This delay on both ends, he confirms, it's causing serious cash flow issues. So we might see some labs in some serious crunch sometime soon. Right now, doctors like both of you, Dr. Adams and Dr. Tahara, out of good faith, you're still continuing to treat these patients. But how long can this be sustainable?
Well, I think Elliot said a couple of months, and I think that depends on each individual situation. You know, a lot of the office-based facilities are run by onesie twosies. So you have a single operator. As I jokingly say about myself, I'm in a three-man group, me, myself, and I. In a rural area in Western Pennsylvania. There are groups that are bigger and have a little bit more scale, so they sometimes have some larger cash reserves, but at the end of the day, it's measured in a couple of months. And even the other thing that a lot of folks don't understand, even if we eventually get paid for this, that cash flow thing. So for instance, in the month of January, I've already loaned money back to my practice so I could pay my staff. Like I've personally given my practice yet another loan to make payroll. That happens. That's like part of the deal when you're in an OBL practice sometimes, because sometimes cash, but this is a more extraordinary set of circumstances.
Can I ask you guys a question, Bob and Elliot? When you forget regular Medicare where you don't need prior auth or pre-auth, when you do have pre-auth, how many days out do you typically start that process? What has your experience been as far as getting the approval from the time of asking for it to getting it? What do you?
I'll let Elliot answer that first.
Yeah, generally a couple of weeks is adequate for most plans, but they're going to deny it on the back end. Medicare Advantage plans, it doesn't always matter if you get prior auth. They're going to find a way to not pay.
And even if you get prior auth, so I'll quibble with Elliot slightly on that. My experience with Medicare disadvantage plans is that they deny everything up front, and then they send me to a so-called peer-to-peer review where I never get to talk to another vascular surgeon. I'm usually talking to a non-interventional cardiologist or a non-vascular surgical specialist who then will patiently explain to me why the guy with gangrene doesn't need blood flow. And that's usually a contentious discussion. And after I've gone through that conversation, usually we get approval. And then what Elliot says happens, they come back and deny it or try to claw it back on the back end.
We ended up with, and people, there are a lot of people that just don't believe this happens, but we did have a peer-to-peer review with a gynecologist, an OBGYN. They denied a patient with gangrene, and the patient just couldn't wait any longer. I mean, people do not understand the debilitating nature of this disease. And this patient ended up in the emergency room, and they didn't just cut off his toe, they cut off his entire leg, saying, why delay the inevitable? And if only they had an actual vascular surgeon or a vascular specialist on that peer-to-peer, I think this patient would have had a better opportunity to have that leg saved.
Yeah, and you know, it's interesting, and it doesn't even only extend to this. We're talking very specifically to lower extremity codes. Kim, I've had that exact same experience with carotid revascularization.
Oh, no.
And getting denied and then speaking to, and again, I'm not trying to be denigratory to my gynecology colleagues, but don't ask me about the appropriateness of a hysterectomy because I don't know. So it doesn't make sense that they're telling me about the appropriateness of a carotid revascularization.
And coming up next, right here on the Heart of Innovation, we're going to have more on what we hope is just a Medicare glitch that will be resolved very soon, but what patients can expect and what they can do about it to help support their doctors and help keep their limbs intact. So don't go away. Stay with us right here on the Heart of Innovation on KDOW. Don't go away.
Right. Elliot and Bob, what do you guys make of that? I think it's just the SFA code, if I'm not mistaken, without atherectomy between complex and straightforward. One of them, the reimbursement is dramatically lower. And it didn't make sense. Is it the complex one that's dramatically lower than straightforward? I
Straightforward
thought
is
that was a
lower.
glitch.
Yeah.
Well, and it
What's
should be, but
interesting?
one didn't make sense. One of them is
Well, it also
disproportionate.
depends on your site of service, right? So there's some offsets between ASC and office.
I'm just talking OBL, just talking office and the
OBL.
SFA territory. One of them between complex and straightforward is switched, and it's actually less for the complex where it should be more. I thought it was the straight SFA.
Are you sure it's not the add-on?
It's definitely not IVL.
No, well, but you know, you've got an add-on the second vessel because that did come out in the new code set, right? So you can
Oh,
do
right. We have two territories
plus
between
femoral
complex.
popliteal. But I think by and large, no, I mean, I'll have to look at the
Okay.
exact sheet again because there's a lot of codes, but even though
So
I've given
many.
3 webinars on this crap so far. But having said that, no, I mean, most of the straightforward codes went down over the single codes that we have now, as you know, Todd. And then
Yep.
the complex one got some buffering for some of the added resource. I mean, and it's way out of the scope of this conversation, obviously, how they arrived at that, but that's a whole separate
Yeah.
ball of
What
wax.
kind of verbiage are you guys using? I always use the word occlusion because occlusion means occlusion, but my billers are telling me use the word 100% occlusion, which is Department of Redundancy Department.
Right.
Yep.
But I'm told to do that because the person at billing on the back end wants to see 100%.
I think that there is some utility to being as specific as one can be. What you don't want to do is say 100% stenosis, right? I had a question on one of the other webinars that I presented about that. That's lunacy. I would simply say 100% or completely occluded. I typically just dictate completely occluded, right?
I
And
do
I
as
think
well. My
what's
billers are telling me to change it to say 100%
I think if
occluded.
you dictate completely occluded, you're safe, Todd. But what I would say is if you have a non-invasive study which highlights a complete occlusion before you do the case, particularly duplex, not so much CTA, but duplex, that is going to be very difficult to refute because then if you get in there and you wire it and now you got a trickle of flow and they want to say, wait a minute, that wasn't an occlusion. That should be a straightforward case. And let's face it, part of this binary function they've come up with is to make auditing very easy.
Yeah.
I mean, that was baked into the cake of this. So
Yeah.
I think as long as you annotate that you're completely occluded preoperatively, that you're in good shape.
Okay.
Yeah, on that note, I find myself obtaining more preoperative CT angiograms now just to double check documentation and cross our T's and dot our I's.
I think you're actually better off with the duplex, to be honest with you. I mean, we could debate this for on and on and on, but if you get a duplex is going to be way more sensitive to subtotal occlusions than a CT angiogram because the flow dynamics. And so if it's occluded on a duplex, it's occluded, period, end of story, we're done, right? A CTA, as you well know, especially if you've got multi-level disease, and I don't know if they'll ever get that sophisticated in having that argument, but it is problematic. You guys have to pardon
Funny,
me.
I guess I'm a poor utilizer of resources. I do both. I feel like I love the CTA because that's my access. I agree with you, Bob. Duplex gives you way more, but CTA will tell me where I can get my access safest and quickest and best. So I love CTA for everybody.
Don't use too much CTA for pedal access, and since that's all I do, I don't know anything more about it anymore.
Do you really? That's all. That's
I've done
amazing.
100% pedal access since 2013.
Wow. So yeah, you don't need it, I guess, if you do that.
I'm probably
And you're good doing 5-6 slender
pedal now.
Yeah.
Are you guys doing 5-6 slender?
I hate slender sheaths. What I use is the halo sheaths. The slender sheaths, nice. Wrap, they kink, and you can get an arteriotomy problem if they move their ankle or stuff like that. So I use those early, like 2 cases, and said we're not doing this anymore. So I use standard 4s or a 4-5 halo.
Mm-hmm.
Nice. What about if you want to use like a spur? Have you have any experience with the spur stent at 6?
Yeah, I did the first clinical case in PA, and I'm.
Would you use? Did you use the Halo 6 for that?
Yeah.
Okay.
I either upsize to a halo, or we've done some very off-label things with barebacking things.
I personally go 4-5 slender in the
30
foot every time, and a halo up if I need more pushability to cross long SFA.
I'll just caution you, be careful on that, Elliot, because you'll get an arteriotomy problem at some point for pedal.
Dr. Berlin, do you want us to take us back?
No, I'm going to leave it to you. You're good at the take back.
Deadline. The when passage of the bill, the president agreed to fund Homeland Security at current levels for 2 weeks. This is SRN News.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. Dr. John Phillips is on call, off saving those piggies, and in for Dr. Phillips, co-hosting is Dr. Todd Berlind. And today we're talking about a potential, what we hope is just a Medicare glitch that will soon be resolved, that is impacting the millions of patients across the U.S. with a disease that's more prevalent than most cancers combined, known as peripheral artery disease. You get those leg cramps, you get leg pain, neuropathy. It might be poor circulation in the legs. And the doctors who are treating this in an outpatient setting are not being paid by Medicare contractors, Noridian and Novitas. And we are talking to several vascular surgeons about the potential impact of this. But I want Dr. Tahara to reiterate what we have talked about during a couple of the breaks, which is it's not just vascular surgeons. There are other specialties that are impacted by this glitch.
Yeah, there are a whole lot of folks out there who are working really hard to save people's limbs in office-based facilities that are interventional cardiologists and that are interventional radiologists. And, sometimes vascular surgeons kind of get, I hate to say the limelight because half the time people don't know what we do, but when we're drilling down into peripheral arterial problems, a lot of times that's kind of the default terminology that's used, but it is definitely a multi-specialty effort across the United States, thank heavens, because there's not enough vascular surgeons to do it all. And so having more people involved in this is actually a positive.
And so what does this mean for patients? I would imagine that if Medicare is coming to the doctors and saying, hey, you did the procedure, we're not going to pay the bill, that suddenly this is going to end up with a letter to patients who are then going to in turn call going, why am I getting this bill for thousands and thousands of dollars? What are we going to do? What's your best advice for them during this process?
if you're talking to me, I think most of the practices are going to try and minimize patient involvement in it as we're fighting through this. I think the bigger issue will be if people can't afford to keep paying their staff, and then they will have to cut back on their schedule, and there will be delays, which I think you alluded to in the earlier segment, can directly lead to limb loss. I mean, in a really truly critical situation, time is tissue, and the sooner we restore flow to that tissue, the better the patient's outcome is going to be. So I think that would be the biggest single thing. I think from an action perspective, what can patients do? Call your elected representatives, your federal elected representatives. And I would loudly complain about this problem because, nothing gets a federal agency to start moving the gears a little bit quicker when 4 or 5 congressmen or senators submit a congressional inquiry. Why is this happening to my constituents?
And I hear on February 11th, there is a PAD caucus that is happening. I'm curious if that's already in discussion to ensure that someone is bringing this up in those 5 minutes that one vascular surgeon or specialist may have in front of them.
Well, I'm going to be one of the people testifying before Congress that day at
Fantastic.
the PAD caucus, and I'm specifically being tasked to talk about some of these reimbursement issues. Most of what we
Good
were going to
timing.
talk about was the problems that we've had with reimbursements. This is going to take a front seat.
I mean, this isn't an isolated case. We have a great conversation that is unfolding on LinkedIn right now. Dr. Feldbaum is talking about they're having issues with IVUS which is intravascular ultrasound for those, general public that are watching this. Aetna Insurance is doing that, both arterial and venous cases. They're seeing delays and denials with it. They wonder if anyone else is having issues. They said they've always been paid before 2026. It's happening in the OBL and ASC. Another person, Dr. I can't pronounce Palanipian, he said it's not just Aetna, but UHC, United Healthcare, has also been denying IVUS at random for the past 2 years in
Yep.
his experience. Same documentation across, but they're just denying some patients, no idea why. Is this something that you guys are experiencing and addressing as well, or have any idea why they're doing it? Why do they keep coming down on PAD?
So again, I'll let Elliot talk about what his experience with this, but I'm going to make 2 quick comments. I'm going to shut up. The first is what these insurance companies like to do is term something experimental until the data is so overwhelming that it would break your fingers if you got hit with it. And they will use this to hide behind and prevent payment for long periods of time. I had this even locally with a payer for IVUS, the intravascular ultrasound issues, and for venous applications. And they were denying my claims, even though I was on faculty there, and I was one of the lead authors of the pivotal paper that proved that this is what you have to do with every case. The second issue with why does this keep happening? There's been a lot of unfavorable lay press about outpatient treatment of arterial disease. And we've really, I think, in an overzealous quest to self-police and to try and, be a wee bit holier than thou about whether or not people are doing appropriate things, we've basically created an environment of fratricide where it's raised the level of consciousness, and the regulators and the payers and everybody feels that, well, boy, we have to scrutinize this. And it's unfortunate because the overwhelming and vast majority of people out there are like the guys sitting on this conversation right now. We're all doing our level best to try and save these people's legs. So those are my 2 cents on that. Elliot, please, I don't want to take all the time here.
Yeah, specifically on IVUS, I've had the exact same experience with UHC. They deny it routinely. Personally, I feel anecdotally with IVUS, I can achieve a much more technically satisfactory outcome than without it. So I just eat the cost on those patients because I think complex PAD, you need IVUS to really see how to treat the vessels. But
So
that's,
coming up
that's
next right here on the Heart of Innovation, I have a big question for all 3 vascular surgeons on this show because I am completely baffled that these hospitals are getting carte blanche approval by insurance companies, including Medicare, for amputations as frontline treatment without even following society protocols for restoring or even attempting to restore blood flow prior to any amputation. And yet they're denying and delaying all of these very important limb-saving procedures. We'll get their comments next, right here on the Heart of Innovation. Don't go away. And Dr. Berlin, you're not getting out of this one. I think you should lead the charge on this final 4 minute.
Sounds good. All right, we'll do it.
We
We'll
don't
do it.
have, like, literally, this is the hard stop at 4 minutes. So if I don't say anything through this whole thing and you guys hash that out, that would be amazing. Hash
Okay.
that out, and then final thoughts would be great.
Is there a timer? When I do this on Dr. Radio for that hard stop, when there's a national syndication and commercial, there's a timer, so I could see it to the second. I just see Chris sending in the countdowns at 1 minute, and then I don't see
Yeah, he'll
anything
do
after
1
that.
minute. He'll do
And
1
then you just
minute, and
gotta-
then he'll send 1 minute, and then he'll send 30 seconds, music starts. So when he says
Got it.
30 seconds, music starts. And I don't care
Got it.
if you have one more thing to say and want to close it up, just close it up. Because it's more important to get the information out of there than worrying about whether or not I'm going to come back on.
Sure.
And all you have
Sounds
to
good.
say, hey, continuing discussion. Thank you so much, everyone, for joining us. Period.
And heck, Todd, you have a platform. I mean, I think this is something that you can extend onto your platform. I'm happy to help you.
Yeah,
do that.
let's chat about it. Yeah, I do that every other Friday morning. I just did it yesterday, and I just learned about this yesterday afternoon. So at the next go around, 2 weeks from now, it'd be great. Let's make this a topic and talk about it for sure.
Yeah, and feel free. Do you want to just in the end just say, hey, we're going to continue this conversation on my Sirius XM radio show in 2 weeks.
Sure.
Here's where
And then
to
maybe we'll have some more information. Yeah, that's great.
Awesome. Yeah, this is amazing. It just I can't believe we just had two last week in one in Arizona, one in Milwaukee, where you were just they wanted to cut off the toes without restoring blood flow. They knew there was a blood flow issue, and in at least one of the cases, I talked to the vascular surgeon, and I said, so you're going to cut off the toe. There's no blood flow. What are the chances he's going to leave the operating room with his leg? And he's like, well, the patient is not going to agree to a leg amputation, but they're going to sign it because we're going to warn them that if there's no blood flow to the toe and we cut off the toe, we have to take the leg. And I said, you might want to start with your taking the leg because that's what you're going to do. So we were able to get him transferred to, I don't know if you know Dr. Ramaya, but Dr. Ramaya was behind the scenes going, Kim, get him to me, get me this patient.
We had that Amputation Prevention Act that got stalled out purely because of politics, right? We had bipartisan support, and then one of the sponsors ended up passing away, and then the person who was supposed
30
to
seconds.
set up ended up getting sideways politically with people, and it just, they got themselves arrested protesting ICE, and so now all of a sudden that just vanished, right? And so it's really become really sad.
Yep.
Go to our website at www.alameda.
We have doctors that are on here that are saying we got to get the patients involved. We need patients to, as you said, Dr. Berlin, get in touch with their representative.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi guys, welcome back. Dr. Todd Berland here in the panel, as you've seen, joined by Kim McNichols. I'm a vascular surgeon based out of NYU. We're talking about Medicare and the other payers not paying for vascular procedures, for procedures to treat peripheral arterial disease. Don't even know the scope of the problem yet because we're still in the first month of January here, and this is going to be a big, big problem. I kind of want to, but I don't want to, but I'm going to put Bob and Elliot a little bit kind of on the spot, and I'll start. Cost per patient. When you have somebody coming in to treat a PAD patient, and you've done the cost on this, as I'm sure you have, in New York, I know our rent is a lot, but we're paying about just over $6,000 per patient to bring them in for a PAD case where we're having to use all the tricks and tools and things. What kind of number do you guys throw out? Because we're talking about not being paid on these procedures. And when a doctor does this in the hospital, it's just your time that's lost. The hospital eats any kind of cost for something not being reimbursed. But when you do this in the office setting, the doctor's not getting paid and the doctor's losing, in my case, $6,000 per patient treated. What do you guys think from a number standpoint?
It's about 7 out here. As a solo operator, you carry most of the cost yourself, so 7 to 8 grand per patient.
Wow.
So I think that's true here too, Todd. But you know,
I thought it'd be more.
right, the real estate differential, we're just talking consumables, right? I'm not worried
Right.
about the real estate differential. The direct costs on a lot of these cases, I mean, when an atherectomy device is a couple of $1,000, and let's
Right.
say for argument's sake, we're going to use intravascular lithotripsy, and that's a whole nother ball of wax because of
Yep.
how they're charging for that. It's like $3,500
Yep.
plus
Exactly.
generators. You know, stents can be anywhere from $600 to $1,200 to $1,800, depending on the length and the manufacturer. Balloons are a couple $100. Every wire I use, 018 wires, it's $200.
Yep. Right.
Right? That stuff adds up.
Yeah. And this is the scope of the problem, because in the hospital, somebody doesn't get reimbursed. You're doing something pro bono. No big deal. It's your time. Takes an hour, takes 2 hours. That's it. But now this is a time and money problem. So this is going to be a big issue. And if anything, I've learned about this, and I think we need to shed some light on this on some other sides and other parts of my practice as well.
So I don't understand. How is it that amputations are being approved carte blanche and limb-saving procedures continue to experience this wrath?
I have no idea.
That's a really complicated answer, but I'm gonna try and distill it down to a couple of key elements. The first is there's still not enough people doing high-end critical limb or chronic limb threatening ischemia intervention, right? People will do interventions, but doing big multi-level interventions, going down below the knee, going onto the foot, that's still, relatively speaking, a minority of the operators out there that really are invested in doing those type of complicated procedures. So number one is, even among limb salvage folks, there's a graduation in how in-depth or how aggressive they're going to be to try and get that. So there's a supply problem. The second issue on the economic part of it, sometimes the upfront cost of doing an amputation can be less. Now, President Obama famously and erroneously said that the doctor would rather cut off the leg than save it back in the day. And it's actually reversed, because when you start to actually look at the costs of these things and you add all the costs of amputation to it, now it far exceeds the cost of doing a revascularization. So if we take the human element out of it, which we should never do, on an economic basis, it doesn't make sense. But because it's a smaller number for the actual procedure itself, all the other costs, the nursing home placements, the rehabilitations, the complications, the prostheses, get lost in the sauce.
And
This is a
Dr.
big
Berlin,
problem. I
where's
think we're
this
kind of
continuing?
Sorry, big problem, but we're going to wrap this up right now. We're going to continue this conversation, though. 2 weeks, we'll know a lot more. SiriusXM, Channel 110, Friday morning, join us. SiriusXM, Channel 110, Dr. Radio. Dr. Tahara and myself will talk about it.
Journalist Kim McNicholas. And
all right.